Let's start with the cases. How do we know this is in the pleura chest wall and not in the lung? There are certain features that are going to distinguish things in the lung versus things outside the lung. And when we're talking about something out here outside the lung, we're talking about pleura and chest wall. When we're talking about something here outside the lung, we're talking about pleura or mediastinum. So how do we make that distinction, and then what diseases or tumors or various other things can cause that? Here's another example of how you can make that distinction. So in the lung or outside the lung, and then the other question that you would want to ask yourself in this case is why there is air in this thing. How did the air get there? Okay. There's not a huge amount of stuff to talk about in pleura and chest wall. It's hard to fill 20 minutes actually, and of course Tom Urbania stole some of my thoughts. So what is that? Tom talked about this a little bit. We'll mention it one more time because it certainly is something that is adjacent to the pleura and may be mistaken for a lung cancer. And what are the features you will see? Okay, this is sort of a classic chest x-ray. Diagnosis, basically only two things this could potentially be. And then what underlying exposures would you imagine the patient had? And lastly, here's a pleural effusion. It's not your plain old nondescript pleural effusion. It has something associated with it, and that sign is fairly specific for one diagnosis. So let's start with pneumothorax. This is something that is pretty basic, but very important. There are certain things that you should never miss on a chest x-ray. Line and tube malplacement. But pneumothorax is certainly one of those. So we'll briefly go over pneumothorax. A nice example of someone who's post-trauma, has multiple rib fractures, which you can see here. It's actually already had their clavicular fracture fixed and has a pneumothorax. So pneumothorax, most commonly traumatic or iatrogenic, but certainly you can see it in patients in the ICU. You're getting daily chest x-rays monitoring them, and all of a sudden they pop a pneumothorax. How does that happen? That happens via something called alveolar rupture, where because of the high pressures it's required to ventilate them, the alveolar wall actually ruptures and air dissects into the interstitium and can come back into the mediastinum and produce pneumomediastinum, or it can go out into the pleura and produce pneumothorax. So that's that mechanism. And then there are other things. If you had a big peripheral cavitary metastasis, that can perforate into the pleural space. Really any cystic or cavitary lung disease can cause pneumothoraces, and other rarer things like those too. Okay? Obviously, on an upright chest, pneumothorax is usually a relatively easy diagnosis. In a supine patient, it often is difficult to make the diagnosis because you don't see that nice edge of the lung, that pleural line. And the most commonly quoted sign of pneumothorax in a supine patient is the deep sulcus sign, where the costophrenic angle is very deep and very lucent. And you often don't see that nice pleural line in these cases. So don't miss that. Sometimes you'll see patients who have just a unilateral lucent hemithorax because the pneumothorax is anteriorly layering in a supine patient. So always consider pneumothorax in any abnormality which is too lucent. Here's this patient again. We saw this patient already. In this case, the pneumothorax is actually subpulmonic. You can see this curvilinear lucency interposed between the diaphragm and the lung. How do I know it's not pneumoperitoneum? Well, I don't see diaphragm above it. If it was pneumoperitoneum, I should see a nice little slip of diaphragm here. So in this case, the pneumothorax was previously out here, and for whatever reason, it's now subpulmonic, layering between the underside of the lung and the diaphragmatic surface. If you're not sure, if you see a lucency which could, around the pleural space, that could be a pneumothorax, what do? My personal preference is to get decubitus views. I think it always solves the issue. And you want to put them the side down, opposite you suspect a pneumothorax. And this is particularly problematic in kids because pneumothoraces go in to weird locations. So here's a decubitus view in this kid, and clearly that thing, that lucency, which could have been pneumothorax or pneumomediastinum, was a pneumothorax. And this is a surfactant deficiency kid. They actually behave in some ways similar to ARDS. And when they develop alveolar rupture because of those non-compliant lungs, you almost always have to put a chest tube in because you're not going to be able to ventilate them without having high pressures. Okay, so back to the question of, is this in the lung or outside the lung, and how do we make that distinction? Well, clearly, when I show this to people, everyone says it's inside the lung, but few people can really verbalize why they think that. And you're right, it is inside the lung. So things in the lung tend to be spherical. Things in the pleura tend to be more elliptical. Things in the pleura are limited by a plane. So they tend to grow, elongate along that plane, but they don't elongate in the other direction, okay? Things in the lung are surrounded mostly by air, so they tend to be fairly sharply defined most of the way around. Things in the pleura, half of it's bordering air and half of it's bordering the chest wall. So at the best, you'll see half of it, and the rest of it will be obscured or silhouetted out by the chest wall. And you turn that patient, and even subtle differences in obliquity of the X-ray will make lots of borders indistinct. So changes with positioning also are typical of pleural lesions, or pleural or chest wall, or mediastinal. And then where a parenchymal lesion touches the pleura, the angles it makes are acute, whereas something in the pleura or chest wall or mediastinum will have obtuse angles with whatever it's touching. Spherical, looks pretty well defined all the way around. Acute angles where it touches the pleura, very typical parenchymal lung lesion. This is a lung abscess. You absolutely do not want to drain this. You want to treat this with antibiotics, because if you drain this, what happens? You get empyemas, and then you get bronchopleural fistulas, and bad things happen, okay? As opposed to this, which is fairly elliptical. It looks like it's growing sort of more superior, inferior, and not so much anterior, posterior. So it's much larger in this dimension. Looks like nice border here, but you don't see any border in the lateral view. So significant portions of the border are ill-defined. And where it touches the diaphragmatic pleura, that angle is obtuse. That's a pleural empyema, and that has to be drained because antibiotics usually don't treat these appropriately. Another example of a pleural or lung lesion, which one? Well, it looks pretty elliptical. It's not spherical. I see about half of it. The rest of it is obscured by the chest wall, and the angles that it makes with the chest wall are obtuse, greater than 90 degrees, so it's a very typical pleural/chest wall lesion. On the lateral view, don't see it at all. You would expect if this was in the lung, unless it was invading the chest wall, which is always possible, but if this was in the lung, you should see it on both views pretty well because it's surrounded mostly by lung, okay? That actually was a chest wall plasmacytoma. Here's something that's not a breast implant, believe it or not. This is a big, huge lung mass. Looks round. We got multiple acute angles where it touches the pleural surfaces, very well defined. Silhouette sign tells me this is going to be a lower lobe posterior lesion because the heart border is intact and the dome of the diaphragm are intact. That was a big lung cancer. Okay? Distinguishing a lung versus an extrapulmonary lesion is not as accurate for big masses. This is an example of a lung cancer that has obtuse angles with the mediastinum, and the reason for that is that it's actually invading into the mediastinum because it's an aggressive lesion. So if it's a small lesion, this distinction is usually quite accurate. As it gets bigger and bigger and bigger, particularly when it's very aggressive, it becomes somewhat less accurate. Differential for pleural and chest wall masses, loculated effusion, some of the benign mesenchymal tumors, lipoma is a very common tumor we see in the pleural space. Some of the malignant mesenchymal tumors. A classic one is a localized fibrous tumor. And mesothelioma usually presents with concentric nodular pleural thickening or pleural effusions. Occasionally that will present with a solitary pleural mass. Metastases, again, the same thing, usually multiple lesions, but occasionally just a solitary mass. And then some nerve sheath tumors extending off the intercostal nerves can mimic a pleural lesion, look like a chest wall lesion. And then there's some other bone tumors, metastases and others. Okay, big mass here. Looks like it's probably extrapulmonary because of the angles it makes with the chest wall and the fact that you see a lot, you see a nice border here but not there, but a big mass. So this was actually a localized fibrous tumor of the pleura, which tend to be quite large when they're discovered because most patients are asymptomatic. You have this enormous mass, and it grows and grows and grows until finally they get a little bit of chest pain or a little bit of cough from adjacent lung reaction. About most of these are benign, but they'll all be resected because there is a possibility of them being malignant, and biopsy is not usually good at distinguishing those. The classic sort of PIMP question is a patient with hypoglycemia and a pleural mass. There are other things that you may see. Again, most of them probably that we see in clinical practice are incidental. So it tends to present with a very large mass in the pleura, and on CT, you have a single mass that may or may not necrose and may or may not calcify, and it tends to show very heterogeneous, particularly delayed enhancement, kind of patchy puddling of contrast in the tumor at about a 3-minute delayed image. And you can see large feeding vessels as well. Okay, here's a mass. How do I know that this is not in the lung, even though it projects dead center in the middle of the lung? Well, superior border is very, very indistinct. If this was a nice round lung cancer, you would expect to be very well defined all the way around. So even though it's projecting in the middle, this is a pleural lesion. Where is it going to be? It's going to be in the fissure. That's a pleural location. There's the lateral view showing the nice fissure. You can actually see there's thickening of the fissure and then this more localized mass. So this is someone with heart failure who has a pseudotumor. And these are not usually loculated, but for whatever reason, they collect in the fissure and can come and go. And actually, even though they persist, sometimes you see them and then they go away and see them and they go away because of the obliquity of the X-ray beam. Okay, what about that contour of the diaphragm? That diaphragm has a weird contour. People often mistake this for elevated diaphragm. Maybe someone has some phrenic nerve issue or whatever. So, but what is this actually? This is actually a subpulmonic effusion, and it's a classic appearance in that the subpulmonic effusion, the quote diaphragm, peaks laterally. It's like this little ski jump. Goes up here, peaks up there, and then it scoops down. Okay, so there's several things that can look like a diaphragm. One is the subpulmonic effusion where the peak is lateral. The other one is combined right middle and lower lobe collapse where the peak is more medial. This is very commonly missed. Everyone, particularly our ICU people, confuse this for an elevated diaphragm, but the elevated diaphragm, the peak should really be in the center, no matter how elevated it is. And this is very typical right middle and lower lobe collapse. There is an elevated diaphragm, which is commonly due to phrenic nerve disease. People sort of wave their hands and say it's due to a viral infection, but who knows? Okay, case number 2. Why is this a pleural lesion? Well, looks elliptical, not round. And then look at that superior border, how that's a very indistinct superior border. And then the lateral view, we see how the angles this makes with the pleura/chest wall are obtuse. So a very typical pleural lesion. We have a little bit of air in it. Why do we have air in a pleural effusion? There's lots of causes for pneumothorax, but let's say you have a big pleural effusion that has air in it. Why? How does that air get there? Here it is on CT scan. Just to confirm, this looks like pleural fluid. There's lots of pleural thickening. And what does that mean? It means that the effusion is exudative. That's all it means. And it's very specific. If you see pleural thickening, it's almost always exudative. If you don't see pleural thickening, it can be exudative or transudative. It's hard for us to tell. So an exudative, probably loculated pleural fluid, because you have these big rounded components that are non-dependent. And then you have a bit of air in it. And there's a few reasons you may have that air. One is that, so this is an empyema, and most commonly these are the organisms. It's usually on CT scan looks loculated, looks exudated with that pleural thickening, and the pleura often enhances. You see the split pleura sign, and the air may be because the patient's had a tap, which is the most common by far, or the patient could have a bronchopleural fistula, which is not uncommon at all. You get a cavitary pneumonia, it perforates into the pleural space, you get infected pleura, and you have a communication between the bronchus, the cavity, and the pleura, so that may produce air. And then rarely you see gas-producing organisms, but this is by far the rarest. And the treatment has got to be drainage in the vast majority of cases, as opposed to a lung abscess where you absolutely do not want to drain it, and you give antibiotics only. How do we distinguish on CT scan in particular, benign versus malignant pleural disease? In the end, it's all about the fluid, but there may be findings to suggest one or the other. And these are all specific, fairly specific findings of malignant pleural disease. If you see thickening that's over 1 centimeter in thickness, if you see a lot of mediastinal pleural thickening, benign processes usually don't produce thickening along the mediastinal surface. It's usually more of the peripheral pleura away from the mediastinum. If you see thickening that goes all the way around, that sort of follows with the mediastinal disease, mediastinal thickening. And then if you see any pleural nodularity, and obviously if you see an enhancement that's invading into the chest wall. Okay, so these are all very specific findings of malignant disease. Of course, in many cases we don't see these findings, and it's all about the fluid. Here we see multiple abnormalities, sort of overlying the mid portions of the lung. How do I know that these are pleural in nature as opposed to lung nodules? Well, this one in particular I think is a good example. One, you have some components which look pretty high density, so it makes me think that some of this is calcified. And everyone appreciate how there's a very nice border where the arrow is. All right, and the other side of it was ill-defined on the chest x-ray. So one side was nice and well-defined. The opposite side was very ill-defined. Again, very typical pleural lesions, things in the lung, well-defined all the way around. And that was someone with pleural plaques, an asbestos-related pleural disease. Here is a classic example of an asbestos plaque. Looks high density, a little bit of calcification, but even the areas that are not calcified are high density. The edges are elevated. Usually other benign causes of pleural disease, they taper at the edges, and here the edges are straight. We call this the Mesa sign. It's just we made that up. You know, the areas in Arizona have those little mountains, the mesas, okay? The earliest manifestation of asbestos-related pleural disease is pleural effusions, which may be seen fairly soon after the exposure. They are often exudative, so you'll see lots of pleural thickening. They may be loculated, so you'll see pleural thickening and enhancement. Pleural plaques are the most characteristic and diagnostic feature of asbestos-related pleural disease, and this is a classic example. And again, the edges are elevated. They may be high density even when not calcified. And clearly you want to distinguish benign-related asbestos pleural disease from mesothelioma, and we would use those signs, greater than 1 centimeter circumferential thickening, significant involvement of the mediastinal pleura, et cetera, to try to make that distinction. I see Marjan in the audience. Marjan's one of our residents. And I like to pick on one resident per resident review. And Marjan taught me the important lesson that the os of asbestosis is fibrosis, said with a Texas accent, right? And Marjan will come up and take the next 20 cases. All right, here's another example of an effusion, which is exudative. How do I know that? By pleural thickening and enhancement. This is another example of asbestos-related pleural disease. This is much earlier in the process. So this is, again, the earliest manifestation of asbestos-related pleural disease. In association with that is this finding, which Tom went over briefly. Here's a mass associated with the pleural abnormality, and we see several findings of rounded atelectasis. This is classic rounded atelectasis. We have a pleural abnormality. We have contact with the pleura between the abnormality and the pleura. We have volume loss manifested mainly by displacement of the fissure posteriorly, and we have this swirling of vessels. If you see all 4 features, you can be pretty comfortable that this is rounded atelectasis and no further follow-up is required. Here it is in the sagittal view. You can see this nice swirling of vessels. Very extensive calcified pleural thickening with volume loss, almost circumferential, but very high density, so it's very heavily calcified. So as opposed to a case of mesothelioma, where it's not calcified, this is something that looks benign. This is a fibrothorax, which is typically due to prior empyema or prior hemothorax or old tuberculosis, usually with a tuberculous empyema. Here it is on the CT scan, nice circumferential areas of calcified pleural thickening. Very typical. There's your differential diagnosis. All right, what else do we have here? Nearing the end. Nice example of circumferential on chest x-ray. Circumferential nodular areas of pleural thickening. If you wanted to measure this, you'd be well above 1 centimeter. So that rule suggests that this is very likely going to be a malignant process. There's the CT scan, just confirming lots of mediastinal pleural involvement, greater than 1 centimeter, nodular. What's this going to be most likely? Most likely this is going to be mesothelioma, but metastasis certainly is in the differential. Pathologists used to have a problem differentiating these two, but in reality they don't anymore. So you can usually tell the difference between these two. And then, we talked about thymoma in the context of multiple pleural nodules, but usually it's these smaller nodules, not this nasty concentric circumferential thickening. Here's a nice example of mesothelioma, circumferential, greater than 1 centimeter, significant involvement in the mediastinal pleura. Very typical mesothelioma. There are a couple subtypes of mesothelioma, a few subtypes, epithelioid and sarcomatoid. That's not really all that important. And mixed types, strong association with asbestos exposure, and this is really the latest manifestation of asbestos-related pleural disease, or I should say asbestos exposure, occurs very, very long period after the exposure. It may also be in the peritoneum. Now, mesothelioma classically looks like that. We have this rind of soft tissue surrounding the lung, within the pleural space, but it can have other appearances. It can present with a solitary mass. Or it can present with a pleural effusion with little areas of pleural nodularity and enhancement. This is more commonly seen with just regular old metastasis from a lung cancer or something else, but you can certainly see this with mesothelioma. In our experience, this is more common with the sarcomatoid type, whereas the other is the more typical of the epithelioid type, but it's pretty variable. So it's another example of mesothelioma. Here's our last case, someone with lung cancer. What's the specificity of that finding? Nodular pleural thickening and enhancement for cancer of some kind, whether metastasis or mesothelioma, very, very high. So it's a good sign, regardless of cytology, and this is lung cancer with pleural metastases. And then there's a nice example of a big pleural effusion with an area of enhancement invading into the chest wall in someone with a metastasis, metastatic adenocarcinoma.